Welcome to this video about distal radius fracture. In this video, we will talk about some points. First of all, we will talk about the anatomy of the distal forearm and the wrist. Then, we will explain some variants around the wrist, the lines, the angles, and the relationship between them. Finally, we will discuss the case by showing the X-rays before, during, and after the surgery, and how to apply the keywords, the suitable positions, directions, and the numbers. See you after the introduction badge. Welcome again. When we talk about the anatomy of the wrist, we should keep in mind that this area is very complex, as we have 8 bones at the wrist, 5 metacarpal bones in addition to the radius and ulna. Here we will talk about the radiological anatomy of this area, starting from distal to proximal and from lateral to medial. Here we see the 5 metacarpal bones, the trapezium, trapezoid, scaphoid, the lunate, the radioscaphoid and the radiolunate joints. The radius. At the middle of the wrist we find the capitate, the hamate with the hook of the hamate, the pisiformis, the triquetrum, the ulnar styloid, the head of the ulna, and the distal radio-ulnar joint. In the lateral view, it's very important to distinguish some shapes at the distal forearm and the wrist. The trapezium, the capitate, the scaphoid, the pisiformis, the lunate, and the ulnar head. Finally, we should always remember that we have a complex structure named the TFCC, triangular fibrocartilaginous complex, at the space shown distal to the ulnar head in the true AB view. So, the displaced fractures of the ulnar styloid may refer to accompanying injuries in this complex to be further studied by MR imaging. What about the normal criteria at the wrist? Here, we have some points to keep in mind in AB and lateral views. The main 3 points in the AB view are the radial length or the radial height, the radial inclination angle, and the congruence of the radiocarpal joint. In the lateral view, we should focus on the radial tilting angle and the relationship between the ulnar head and the distal radius. The radial height, which is shown here, is very important to determine the power of the fist movement and the palmar flexion of the wrist, and it is acceptable to be between 8 and 13 mm. The second important point in the AB view is the inclination angle of the radius, which determines the direction and the plane of flexion and extension of the wrist, and it affects the direction and the range of the ulnar and radial deviation. It's acceptable to be between 18 and 23 degrees, and it's perfect to be restored to 22 degrees. The third point to be focused on in AB X-ray is the congruence of the radiocarpal joint. Here, we should always remember that the radiocarpal joint is consisted of 2 main facets, the radioscaphoid and the radiolunate. And if the fracture line reached the cartilaginous surface of the joint, we should restore the congruent surface. And any step at this surface should be fewer than 2 mm to be acceptable. Otherwise, the open reduction and internal fixation will be indicated to avoid the high chance of having a developing early osteoarthritic change. The first main point in the lateral view is the volar tilting angle, which determines the range of motion of the wrist in flexion extension plane. It's acceptable to be fewer than 5 degrees of dorsal tilting, and it's perfect to be between 0 to 11 degrees of volar tilting. The distal radius in the true lateral view to be acceptable should cover regarding the relation between the ulnar head and the distal radius more than the half of the ulnar head. In this part, we will discuss a very popular case, which is the distal radius fracture type Colles fracture. It's in definition the posteriorly displaced extra-articular fracture of the distal radius. The patient is 67 years old female, came after falling on outstretched arm, complaining about swelling with the typical deformity of dinner fork. This case was treated by closed reduction and KY fixation. This treatment was indicated according to the age, the bone statement, and the presence of accompanying fracture at the ulnar styloid. In this lecture, we will not discuss the typing or grading, but we should always keep in mind some points about the factors that affect the treatment way, which are as the following: the age and the statement of the affected bone, and the presence of osteoarthritis or osteoporotic change. Then, the position of the fracture line and its relation with the surface of the joint. The stability of the fracture after reduction, which determine the suitable fixation way, cast, K-wire fixation, or open reduction and internal fixation. The number and statement of the fragments. Finally, the presence of accompanying injuries, fractured ulnar styloid, dislocated wrist, or fractured carpal bones. Regarding this case, we can see 4 points in the AB X-ray of the wrist. The first is minimally displaced fracture at the ulnar styloid. The second is the absent ulnar variance. The third is that the radial height or the radial length is shorter than the normal, but it's still acceptable. It's about 9 millimeter. The fourth and the final point, we can note that the radial inclination angle is about 20 degrees and it's also still acceptable. In the lateral view, we can see that the tilting angle is reversed posteriorly. It's about 30 degrees. It's not acceptable indeed, so it should be reduced to zero or volar tilting. Moreover, it's the main cause of the dinner fork deformity in Colles fracture. The reduction is usually done by traction according the radial axis with ulnar deviation until we hear or feel a click of a fracture side detangling. Then we apply a dorsal pressure at the distal fragment towards the palmar side to restore an acceptable volar tilting angle. After getting an acceptable reduction in AB and lateral views, we keep it stable by using K-wires. The number and direction of K-wires depend on 3 points. First of all, the number and situation of the fragments. Then, the statement of the distal radioulnar joint. Finally, the presence of accompanying fractures at the wrist or the ulnar head. In the case of simple fractures like these, it's enough to use two 1.6 to 2 mm K-wires, one lateral and one medial. The lateral one is usually inserted from the tip of the radial styloid, and it's better to be central in the lateral view to reach and penetrate the medial cortex. The medial one is usually inserted from the medial radial angle, medial to Lister's tuberosity, and proximal to the surface of the joint. To give an ideal fixation, we should avoid crossing the K-wires at the level of the fracture line in AB and lateral views. See you in the second part of this video, and it will be about malunited fractures of the distal radius.